So it's my honor to introduce our final panel of the day and our special moderator, Paris Alston. Paris is a remarkable young voice in our city. Literally every morning, as co-host of WGBH's Morning Edition, she brings clarity, candor, and warmth. Paris also co-hosts the Wake Up podcast at GBH News and was previously a host of the NPR podcast Consider This, produced in conjunction with GBH and WBUR. We're so pleased to have her with us this afternoon to moderate this panel on policies, partnerships, and the future. Paris.
Thank you so much. Thank you so much. Thank you all. Yay! Oh my goodness, good afternoon. I am really so happy to be here. A couple of panelists know I had jury duty yesterday and I was freaking out because I was like, oh my God, I'm not gonna be able to make it, but I was selected and released all on the same day. I fulfilled my civic duty, so thank you. Well, I certainly am delighted to close out this day with this distinguished panel of leaders in health equity. Please take a moment to look at their impressive bios on the website using the QR code on your program, as I understood you have been instructed to do all day long, because we want to get right to the conversation. So I'm going to do a quick intro of everyone and we'll jump right into it. First of all, I would like to welcome back to the stage Dr. Bisola Ojikutu, who is the Commissioner for Public Health in the City of Boston. Also with us is Michael Curry, who is both CEO of the Massachusetts League of Community Health Centers and a co-founder and leader of the Health Equity Compact. Also with us is Juan Fernando Lopera, who is Beth Israel Lahey Health's inaugural Chief Diversity, Equity, and Inclusion Officer. Also with us is Massachusetts State Senator Liz Miranda, who represents the 2nd Suffolk District. And last but certainly not least, joining us is Dr. Claire Pierre, who is Vice President of Community Health Programs at Mass General Brigham. Let's give a round of applause for our lovely panelists. So we have heard from a diverse array of experts over the course of the day so far, sharing and discussing some of the key challenges, successes, and lessons learned out of COVID, as well as some of the innovative work now happening in different spaces to advance health equity. We've talked about the last few years and today, and now with our final panel, we are going to look to the future. Now this panel will be a dialogue among some of our Commonwealth's key health leaders about what's next to create the more equitable and just space we envision and what's needed to get there. We certainly invite all of you to ask questions. Hopefully we can get to them throughout. I know the Q&As usually come at the end, but I'm a big fan of audience engagement, so just if you got a question, don't be shy. Now, these leaders are all part of the Health Equity Compact, which is a coalition of over 65 leaders of color across a diverse set of Massachusetts health, labor, philanthropy, and business organizations with combined lived experience and vast professional expertise seeking to dismantle systemic barriers to equitable health outcomes for all residents of the Commonwealth. So, Michael, I'm going to start with you and give us a peek behind the curtain into the origin story of the compact. How did this come together?
Yeah, thank you. So first and foremost, just major credit to Dr. Ojikutu and the team at the Boston Public Health Commission. Yes, please. Me being a student of history, I always say right people, right place, right time.
And right team, because
right
it was a team.
And that's real. When you think about movements and how we actually make real deep systemic change in this country and across the globe. But it takes people like the folks you'll hear from today. I will say this, when the pandemic hit, it was no surprise for people who've been in this space for a long time what the result would be. I tell people, and Senator Dianne Wilkerson, former Senator Dianne Wilkerson is here, that one of the worst hearings I ever attended in my life as a lobbyist for most of my adult life was a hearing on pandemics, way before COVID-19. And it was terrifying because they talked about how many people would die, who would be most vulnerable, that we wouldn't have ventilators. It was in the Gardner Auditorium, and it was shocking to me. So I'll start the answer to your question by saying, when I walked in, and I've been getting updates from the panels all day, there's a phrase that really sticks in my spirit, which is, I'm glad so many people are woke and others are waking up, but some of us are insomniacs. What you've had a dose of all day today is a whole bunch of people who can't sleep and have been talking about these issues for a long time And it should not have taken George Floyd or COVID-19 to get people to pay attention. So that's first and foremost. And that last panel was phenomenal collection of insomniacs who've been doing this work for a long time. That being said, we got asked, all of us, there's probably pockets of us in this room that was on every task force known to man and woman over the last 3 years. And I said no to none, local and national task forces, because I just wanted to make sure that there was a voice in the room that represent communities like I came from. Housing projects, Roxbury, a single mother, poverty, welfare, almost every uncle and aunt dying younger and a higher rate of disease, name the disease. And I wanted to make sure that perspective was there. I wanted to make sure a community health center perspective was there as they were on the front line. So Juan and I served on the Health Equity Advisory Group for Monica Burrell, former Commissioner of the Department of Public Health. Jeffrey Sanchez and I, Dr. Seau, and many others served on the State Legislative Health Equity Task Force during COVID. Mayor Walsh at the time had a Health Inequities Task Force. Mayor Sullivan had a Social Justice Task Force. There was a national task force on public health that I served on with Governor Kasich and a few other governors and mayors from across the country. Same things, right? Same things that we should have been prepared for the moment. I got a call after we had produced a health equity task force for the state, and Jeffrey Sanchez said to me, there's no kids in here, so I'm gonna say it the way he said it. He said, this shit is gonna sit on a shelf, and they're not gonna do anything about it. So what are we gonna do? And he thought about calling a few leaders in healthcare and business together to have that conversation. And we had a few conversations, and it didn't really go anywhere. Shortly after came a call from Juan Lopera in his new role. He said, Mike, Jeffrey, we gotta pull this together. Let's figure out what this is. So fast forward, all of a sudden that call did not take long. It took maybe 2 weeks to get all these black and brown folks who run systems. Dr. Anderson said it earlier. We've never seen a moment like this in the history of Massachusetts. I would argue probably in the history of this country, where the folks you see on these panels and in this room actually can make the decision for systems that they run. That means equity is always deprioritized. We can't afford it, we don't have the resources, it's not as important as these 3 or 4 other things. But when you're Claire Pierre and Dr. Gibbons, when you're Dr. Churchwell, when you're Rosa at Tufts or Juan or even in the legislature, Liz Miranda, you can prioritize things that other people don't see that as important. So you pull them all together, and what do you have? You get legislation that moves the needle. The next iteration of health reform in Massachusetts can be a health equity reform bill. I was there in 2005. I was a policy person. There's nobody in the room, sitting in the back of the room taking notes for Blue Cross Blue Shield. Equity rarely came up in those conversations. And why? Because it was mostly white men in those rooms. It wasn't their lived experience. Like, you've been hearing lived experience all day today. They also were, and I would say this because it's when you have a lived experience, you're not accepting to the fact that your uncles and aunts, grandparents die too soon and they're sick. What you're hearing now is a different conversation because the people that we're talking about as a part of this Health Equity Compact bring that sense of urgency that I've never seen in my entire life. Now, I'm going to go back because I think Jeffrey Sanchez led a disparities working legislature, Senator Wilkinson, Representative Gloria Fox, name the many others, Peter Katusian and others who've been involved in this work. The reality is I've never seen the urgency, although they were asking us to be urgent about it. So how do we do something about that? And I'll just say that that work is leading to us now convening and really being disruptive, and I use that word because I think it's important. No change that has ever happened in this country, no reforms has ever happened in this country that were not disruptive. And that's what this work is about.
Juan, Michael mentioned your role in all of this. Tell us about the personal connection that drove you to want to be part of elevating this.
Absolutely. Well, thanks again for the opportunity for have this full day discussion on this critical topic. And as is often said, you can't let a good crisis go to waste, and that's I think the case with what we're trying to do here. So as Michael mentioned, I think it was the first week on the job as the inaugural diversity officer at Beth Israeli Health, where the responsibility around equity was so so large and so significant that I knew the first thing I needed to do is ask for help and reach out to others who have been trying to do this work for a long time, and then figure out how we do it in collaboration. And the task at hand as a diversity officer is enormous, so it needed that level of collaboration. But for me, it was also the personal aspect of it. We all saw the data. We all saw that 2 to 3 times the rate of COVID infections in our Black and brown communities, and places like Chelsea, at one point the epicenter of COVID in the country. And it took me back to 1990 when I came to the US from Colombia as an immigrant, for a long time a non-documented immigrant, and lived in that perfect storm of conditions that people found themselves in Chelsea, where you did not trust any system, certainly not healthcare, because you didn't want to be found out as undocumented. You didn't speak the language. You were predisposed to chronic conditions like asthma and many others, as was the case in my family. Parents were part of what we now call the essential workforce and had to go to work. So you'd fast forward to what happened during the pandemic. It was no surprise to any of us with that type of lived experience. And then to sit there and be part of the Department of Public Health advisory group on COVID and see the statistics, and then to see one at a time several family members die. David Herrera, my father-in-law, died of COVID. He had diabetes, was on dialysis, so as soon as COVID got him, he was gone. 2 uncles, Javier and Ivan Alvarez on my mom's side, both had cancer, and as soon as COVID hit him, they were gone. And then Bernardo Lopera, my uncle on my dad's side, as soon as he was a smoker, as soon as COVID hit him, he was gone. So 4 people. So the statistics, the reports on the shelf, all of that stuff was real to so many of us. And now in a position of influence and power in the roles that we have, we just, it was such a huge sense of responsibility to do something to address these systemic issues that led to what we saw with COVID. And the data was very clear with COVID, so a lot of what we're trying to do with the Health Equity Compact is really translate what we learned from COVID and make health equity measurable. Just like Dr. Williams said, we should be able to measure racism. We can actually measure health disparities in aggregate and hold ourselves accountable for change, and that's one of the key components of what the Health Equity Compact is trying to do.
Juan, thank you for sharing that, and we're all very sorry to hear about those losses. I mean, and so many people were impacted in that way. And Dr. Pierre, I mean, not only hearing the stories of Juan's family members, but just knowing, right? I mean, there were scores of people who were going through this in addition to all the other things that they were dealing with on a day-to-day basis, right? Everyday racism. In the role of a physician, how important is it to have that perspective and to be able to not only meet people where they are, but to know that experience so that you can advocate for them through initiatives like the Compact?
Thank you so much, and thanks, Juan, for sharing. Similar to Juan, I am an immigrant. I came from Haiti, and in my personal life and in my professional life, I've had to twice respond to disasters. And the first was the earthquake in Haiti, where we were personally affected. We lost our homes, we lost friends, family members, and so on. And I found myself in a space of complete despair, but incredible hope, because it was the first time I'd seen global solidarity and I'd seen partnership across sectors. People saw the urgency, and it didn't matter if you were the president of a country, the prime minister, the ambassador, you were lifting boxes, you were helping, you were a surgeon, everyone was together. And then fast forward to the COVID pandemic. I am working at a community health center, actually a network of sites from Boston to the Cape, and my work was to deliver community-based care. And actually, I've only seen patients in community settings. So most people have their clinics one-on-one. My clinics have always only been in basements of churches or in other places in groups. We ate together, we exercised together. But I also knew that the prescriptions didn't matter if housing wasn't secured. I knew the prescriptions didn't matter if DCF didn't call back. I knew, et cetera, et cetera. So my conversations and as a clinician always were informed by this. And during the pandemic, as Michael said, many of us were on advisory groups and were with the policymakers. And I saw again this tragedy. I'm sitting here with my uncle dying and trying to talk to the nurse in Florida about it because of COVID, and they're overwhelmed and so on and so forth. While responding and while being in these policy settings, you start realizing that the dots are all there, but we're not always connecting them. And so, to me, the Health Equity Compact brought something that Michael actually raised. We asked Michael to be a speaker at our community health centers for Juneteenth. And Michael said, are we gonna make this a moment, or are we gonna make this a movement? And so, after a year of all of it, vaccines, so on and so forth, and as I transitioned into this new leadership role in one of the largest institutions in Massachusetts, I realized the Health Equity Compact was a way for me to make this a movement and not just a moment.
And Dr. Ojikutu, I'd love for you to talk a little bit about what responsibility a city has, right, in upholding something like this. I do remember, if I remember correctly, it was shortly before the pandemic that racism was declared a public health crisis in the city of Boston. And so, obviously, shortly after, we had this whole pandemic that exacerbated that. And, I guess in so many ways, we all knew, right, that our municipalities had to be on the forefront of combating that. But what did it mean to be involved with the compact? How did that take that a step further, that responsibility?
So thank you, Paris. I really appreciate that question. First, I'll start out by saying that the declaration of racism as a public health crisis was declared here in Boston in 2020. And it was in the wake of the murder of Mr. George Floyd, and a lot of advocacy by many of you who are probably, in this room. Mayor Marty Walsh declared it at that time. Now, across the country, probably over 200 different cities, counties, other jurisdictions also declared racism a public health crisis. And the question became, is this symbolic or is it meaningful? I've been in many rooms with my colleagues across the country, commissioners of public health, other leaders, and by and large, most of them said this is symbolic. Nothing is happening. There's no money behind the actual declaration. What I would say is that here in Boston, things were somewhat different. We actually did have money, we still have money that has been dedicated to address racism. It's not enough money. As a public health department, we get about $3 million a year, a little more than that. But the reality is we have a lot more work to do. And certainly $3 million is a drop in the bucket when you're talking about the issues that Dr. Williams so eloquently discussed earlier. So let me transition and talk about the Health Equity Compact and my journey to the compact. So I remember when I was invited, I got an email from Michael, and he said, come to the compact meeting. I didn't really know much about it. It was early days at the time. And I went to the meeting, and I have to say that I was a little bit disappointed. And let me tell you why. And I talked to you about this, so there's no secret here. I was disappointed because it was focused in on what happens during the clinical encounter. It was focused in on healthcare institutions. We all know in this room, based on the conversations, if you didn't know, based on the conversations that we've just had, that health and equity does not begin or end within a clinical setting. Okay, we all know this. Morbidity, mortality, life expectancy are highly correlated to the quality and quantity of the social determinants of health that you have at your disposal, plain and simple. Okay, we're talking about structural racism that's leading and driving how people experience the communities in which they live. And that's not what we were talking about at first. Okay, so we had a conversation about it. My colleague in New Bedford, Damone Chapin, who is now at Minneapolis, great spokesman on these issues. We sat and we talked and we said, well, how do we integrate here? What do we do? And we sat down and we talked. And now I think what has happened is that there is a marriage of what happens inside the clinical setting and what happens in communities, in neighborhoods, and related to those life expectancy data that I presented earlier. If you were not here, we have a 23-year life expectancy gap between census tract in Back Bay, versus a census tract in Roxbury. This is updated data. This is not the data from way back when. This is updated data. And my point in saying that is that we still have a lot of work to do, okay? And I think that the Health Equity Compact is one of the many important strategies that we need to implement, and we need to implement collectively. Within the Health Equity Compact, there is there are a number of components that relate to social determinants of health. One is the proposal of health equity zones, which are, if you are familiar with that, these are geographic areas that are identified as being more vulnerable, they have higher inequities, and instead of investing in the outcomes per se, the actual clinical outcomes, the investment goes to the upstream factors. The investment goes to those structural and social determinants of health. And I think what's most important about it, because that's one thing, but I think what's most important about it is that the money is actually meant to go to the community, to lead that investment. So that's a strategy that I would like to see implemented here in Massachusetts. And that's why I joined the Health Equity Compact.
So moving from the city to the state level, Senator Miranda, I know that you are sponsoring a bill for the Health Equity Compact. Tell us more about that and why it's important for you to be championing this.
I hope I can follow my great colleagues, and it's really hot in here. Is it me? No. I didn't open a window. Maybe I'm just stressed out with the state budget. But you were shouting out the senator, and I just wanted to say, to Senator Diane Wilkerson, I learned a lot from you. But one of the things that I learned that was really important was when she would say, "Show me the money," or "Follow the money." And we're a very resource-rich Commonwealth. And I was just dismayed when I got into the State House 4 years ago and 4 months ago. Now I'm in the Senate, I was in the House. How we as a Commonwealth or as a city with the best hospitals, public health infrastructure, an ecosystem that rivals the West Coast on biotech, life sciences, and entrepreneurship, top institutions in the world in terms of education. I like to think it's Wellesley, not Harvard, but, I digress. But the point is, it shouldn't be happening anywhere, but it damn sure shouldn't be happening in Massachusetts. And I walked into the State House, and I think you so eloquently talked about this pendulum of despair and hope, and I kind of talk about it as pain and purpose. I walked into the Massachusetts legislature 6 months after, well, I didn't walk in, I kind of worked hard for it, after my brother's homicide. And I was eroded as a person. I'd been losing people since I was 18. I still remember the first friend I lost, Michael Tavares, who was my neighbor. We went to kindergarten to high school together. But Michael did something different for me as a sibling. And I had a dream job. I was running the Hawthorne Youth and Community Center. I've always wanted to run community centers. And then I was faced 3 months after he died, and it was his birthday, and I was like, I couldn't get out of bed. And I kept saying to myself, I wonder if this is what grief feels like, because for so many of us, when something chaotic happens in our lives, we are paralyzed. But we sometimes do the motions, right? I did everything, bury him, worked with his children, worked with his children's mothers, talked to his friends. I kept making excuses that everyone else was more important in dealing with the pain than my own. I say all of that because I went into the State House thinking that I was gonna work on gun violence, right? I was like, I'm gonna do something about this. I know we have the lowest number of gun deaths. I know that we have tough gun laws, but we're still not at zero. And that's the point. In health equity, we're still not at zero in many of these things. And then the first week on the job, I hear from March of Dimes, and they tell me that the 10 worst zip codes in the Commonwealth for babies and moms, 6 of them were in Boston. And I didn't know what to call it, but then as I walked out the room, I remembered that I watched my baby sister give birth to a 21-week-old baby, and the baby passed away. And the night before, my sister had told her doctor, her provider, that she was in pain, and she was told to take Tylenol because she was anxious and go to sleep, and hours later, she was in forced labor. And so then I'm in the elevator going downstairs in tears, like, I'm not a mom yet, but I don't want to die. I don't want to die. And in tears because I didn't know if I had been the best sister because I didn't know what to call it, I didn't know what to do. And thinking about my mom and my sisters and my friends. I say those two things because so many of us, maybe other electeds won't say this, but we're not experts in everything. But I like to think that there's one thing that I'm expert is in humanity. Like, I didn't take this job to become someone who knew what disparities felt like. I grew up in the Dudley Triangle. I've been living in disparities and inequities my entire life. And so I sat on the Health Equity Task Force, and one of the reasons that I think that it was presumed to go stay on the shelf is we heard a lot of real things from a lot of real people. And there were two sections in that report that I helped write, in the carceral population and on maternal health. And I don't think the state wanted to hear those things because we were saying the things that I heard when I walked in this room, which is that you don't just start at the healthcare system, right? Our communities are killing us. You know, I've lived in Roxbury my entire life, and I lived among 1,400 parcels of vacant land. I knew what a brownfield was when I was 14. That taught me more about the work that I'm doing now in policy and advocacy as a legislator than any book or task force. And so when the Health Equity Compact came to me to file the bill, and it was really strategic, there are 4 filers in the bill. We crisscrossed the state, making sure that Chelsea, Boston, Springfield are represented. There are 2 filers in the House and 2 filers in the Senate because we know all the data, we have this. But what we don't have is sort of a strategy to make all 200 legislators understand that we need to listen to Black communities, period. You know, you keep saying this and they keep finding another reason, but we know what's happening in our communities. And so I'm delighted to be the filer of this, and I made a joke to someone, I can't remember who it was, where I told Mr. Sanchez to slow down. They were so excited about doing these convenings, and I was like, well, us 4 haven't met yet, and I really think it's incredibly important for us 4 not to just file something, but to work a bill. To work a bill and educate not only externally, because a lot of information, like that information that I got as a Black woman in that room, was at me. And as a Black woman, I'm tired, you know. I always hear these poor health outcomes about me, my family, my communities. My community has the highest number of fatal shootings and non-fatal shootings. We get tired of hearing that, but everyone in that building should understand that health equity is their problem and their opportunity. So I'm excited to work with the leaders and the experts. I like to think that we could take the best of community organizing, take the best of policy and advocacy, and take the best of patients and practitioners to actually get this bill across the finish line.
And Senator, I'm going to stick with you for a second because Juan was mentioning earlier just, you know, some of the challenges that people confront when they're walking through a hospital door or a clinic door, fears of you know, being deported, those sorts of things. And there's also a lot of tension around how people interact with the healthcare system, right? People who look like us. And I understand you have some personal experience with that if you're willing to share.
I was thinking about the story that we talked about, because 95% of my job is getting people to do their job. You know, people call me.
I'm sure you're not
with
the
all
only
sorts
one
of
who would say that in this room. Right?
You know, people call me with all sorts of problems, and there have been lots of healthcare and health inequity problems at almost every major hospital. And usually when their backs are against the wall and they don't know who else to call, someone says to them, maybe call an elected official. And it's really incestuous and I think problematic that I can make one phone call and everyone calls me back and changes course. And the families who've been suffering, whether it was someone who was giving birth at a hospital, whether it was a person who called my office because their dad was going through cancer treatment and wanted to switch hospitals. Many people in our communities, even resource people, let's be clear, this isn't just for people that can't speak the language. Hospitals are hard, healthcare is hard to navigate any level of income that you have. But I'll just share another story. For those of you that were at Mel King's funeral, Mel King obviously is someone who has made a lot of impact in our communities. I've known him since I was 14 years old through a program called My Town, where I learned about his fight to secure affordable housing. I learned later that he was a representative. That wasn't the first thing that I learned about him. I actually learned that he was an activist first and a community organizer. His daughter stood up in the services and talked about the quality of quick care even her own father didn't receive. And you could hear a pin drop, because there was all these great speeches about all the great things that he did. And at 90-something years old, as someone who's made such an impact, she was like, I had to fight to get the care that my father deserved and wanted. And so we have a huge problem in our city, in our state, delivering the quality of care we say we actually do, and actually do it for communities and people who are impacted. I'll say the last thing. The beautiful thing about the compact is it's private-public partnerships. Nothing can get done. You talked about movements being led by Black women and young people, but nothing gets across the finish line without the type of partnership with people who can move systems, but also people who are integrated in making decisions at every sector of government. But that one story about Dr. Mel King is also something that I have found, every week there's like a person a day. And for those of you, I see Jay here, I made it a point, and this I'll end here. Most of our community members are getting their care at community health centers. We do a grave injustice to our community health centers. We treat them like redheaded stepchildren. And if you say that you don't, it's not true. I don't care if it's Dimick, I don't care if it's Mattapan, I don't care if it's Upham's Corner. If you talk to any provider or any ED of those institutions or any patients who are depending on almost 95% of their care happening in those spaces, it's their community health center. And they don't get enough money. People are quitting because of the long hours or the intensity. And if I could suggest something, I think my work with my community health centers to not only take them out of the shadows, it's not just about the big hospitals, it's that too. And it's an and thing, investing in community health center care. My dad was sick. He died in February of last year. My grandmother died of COVID too, so I understand the pain is sort of that pendulum of pain and purpose. And one of the things that I saw was that my dad hated going to Beth Israel, sorry. But, he was getting his care from Dr. Jean, who spoke his language at Bowdoin Street Health Center. And Bowdoin Street Health Center was God. It didn't matter if it was 10 o'clock at night or on the weekends. Is Dr. Jacques at work? Call him. Let's go up. Let's pull up to Bowdoin Street Health Center. Because the man knew his experience as a Cape Verdean man, could speak the language, had empathy for my father and his multiple issues. And so when we went to go to Beth Israel, it was almost cold. It was, the person would speak to him for 15 minutes, and my dad would be like, you didn't even ask me what's wrong with me. You just told me that I'm okay and I'll see you in 3 months. So I think that there are some investments, I know, in this partnership, but also in investing in our community health center infrastructure.
Yes, of course.
Yeah, just to tag on, because there's so many incredible points there that the center raised, and just to comment on the incident that we worked through recently. I think it speaks to the importance of the Health Equity Compact and the fact that we now have, I'll use Michael's words, people running stuff to keep it PG, and the fact that we can connect with each other and say we have to do better by that patient, and our systems are failing many, and that's why the data is what it is. And we are in positions of influence. I have a seat at the table at the executive most level at Beth Israel Health, so the feedback we get from the community we can act upon immediately. And as you know, we were able to do that. And as it so happens, Bowdoin is actually part of our system. Yes. So we learn a lot from our health centers. In fact, when it comes to culturally competent, linguistically appropriate care, that is the place. So there's great systems of care in Massachusetts and across the country, but the health centers definitely are the ones that teach us a thing or two all the time. So just wanted to tag on to that, and We're all on speed dial, so that's what the compact is all
I just
about.
emailed Juan.
So I want to talk more about community health centers and come back to you in just a second, Michael, about that. But Dr. Pierre, I want to ask you too, I mean, I think it could seem to be obvious, right? But what is stopping some of our larger healthcare institutions and the clinicians in them from behaving like a community health center, even on a one-to-one level?
You know, it's interesting because my career has gone back and forth between academic health centers and community health centers, and there is a true cultural difference in how we approach care and how we deliver care. And you know, at MGB, we 2 years ago had to stop and realize that we needed to look in and really commit, and not just commit with goals and numbers and a mission to be united against racism, but invest dollars, multi-million dollars, into making sure that the experience of working within our walls was better for our own staff. The experience of receiving care with us was better, and that we partner with communities in a different way. And it's hard and painful work. It forces us to look at who we promote, who we hire, what CVs get in, what don't. When there's an emergency, how do you rush to make the decision? Who do you forget to include? Those are hard decisions, and those are hard conversations to have at every level of leadership. It required us to look in and train our staff. Our researchers, as Dr. Stone mentioned, actually took bold actions and actually looked at our healthcare inequities and published about it. And you think like it's embarrassing to say that our patients of color are not getting the same care, but we have to write it, and then we have to do something about it. And so the heart failure study, for example, was one that many of you probably heard about. It was in the press. It actually, for the clinicians who led that work, they were targeted by neo-Nazis. Mm-hmm. And then you still had to continue to do the work. And so that meant we had to go back and ask our team members, why did you choose to send this patient there instead of there? And it was interesting to see what happens. The way we're trained excludes people. The things that we are taught in structural racism, and this is what makes it hard, it's in every place. It's in what we study, it's in how we are taught, it's in where we get to sit, it's in where we get to live, it just keeps going at every level. And so countering that is a multi-year, multi-million-dollar intentional investment so that we can write and publish about it and use technology. Now if one of our doctors decides to admit to this, we actually have the computer pop up and say, hey, did you notice this person is off? Are you sure that's what you want to do? Because we know that even when people are not intentionally doing it, you need to set reminders. And so I think it's a long way to say that structural racism is real, it kills, and for us as institutions to make a difference, we have to each start by looking at ourselves and then have measurable goals that we track over time.
Michael, when you think about some of the things that we have learned from the pandemic, good and bad, things we want to keep, things that we want to do away with, how does that apply to the relationship between community health centers, the community, and our larger healthcare institutions?
Yeah, so first and foremost, I for those who know me well, know that I used to host a spoken word venue every Wednesday night that Liz used to sneak into when she was at Wellesley College. She wasn't old enough to be there. I'm gonna out her when I say that.
Out in the street. Look.
So she snuck in. But words matter to me. And I just wanted to recognize throughout this course of the day, I've been moved by a few words. Our communities are killing us, right? We think about systemic racism and food insecurity, housing insecurity, unsolved murders, trauma, violence, substance use disorder. That speaks a lot to me. Our communities are killing us, that Liz said. I'm not a mother yet, and I don't want to die. Right, as we know, Dr. Thea James and others, we've been having these conversations about maternal health and the data out of California, the recent data around high rates of death among Black and brown women and our babies. I just don't want that to pass on the moment that we take that in. And then I was on the panel earlier at the Health Policy Forum, and I was serving on the panel around patient safety. And there's a significant impact we talk about to errors human and medical errors on black and brown people in our communities. And one of the speakers got up and said, I shouldn't have to get angry to get the care I deserve. So when you think about the folks in this room who had to get angry to say, you know, the woman stopped me on my way here, and I was late coming here. She said, I need to talk to you and I need 5 minutes. You get that all the time. And she told me, she said, I was in the hospital, I'm a black woman, I live in New Hampshire, and I came to Massachusetts so I can get care by folks who knew me and understood me. And I was in a hospital during that time, and they thought I had COVID, and they put me in a room to have my baby, and I had no one who could talk to me. And she said, all of a sudden, I'm kind of in and out of it, and my baby's laying next to me, and nobody wanted to deal with me. And she said, I had to check myself out, despite the fact that I thought I had COVID. She wanted me to hear her story. So I wanted to just make sure that I just get lost on us, that we have a broken system. And no, Massachusetts, we coined a phrase when I was in college, the best of the worst. Massachusetts is great at a lot of things, but we're crappy at it too. We're just better than a lot of other places. So when I think about this from a community health center standpoint, and what we learned through COVID is, one, we should have known we should have embraced technology. There's no reason in the world we shouldn't know we could work remotely, teach remotely, provide care remotely, that we could engage patients, and we're seeing tremendous data, mental health engagement with black and brown people through technology. Now, we still have to solve for Wi-Fi and the technology disparities, but the reality is more black and brown people are now engaging in healthcare, their mental health, through this system in a way that they wouldn't have been able to do if they had to take a bus, 2 trains, and come to a center and stand in a waiting room. So that's huge. 2 is we learned from organizations like Boston Black COVID Coalition or La Colaborativa, or all these other organizations that, you know, that phrase that came out of the HIV/AIDS movement, nothing about us without us. If you want to solve my problems, if you want to talk and engage my community, have me at the table. Have my mother at the table so she could tell you what works for her. And we didn't do that well before COVID. We came to parking lots, health centers, Guale, and hospital systems. BMC partnered with community organizations to bring care not only to a parking lot, but to a church. I got both of my vaccines at Morningstar Baptist Church. I chose to get my vaccines at the place where I worship. So what can we do if we engage the places of worship around primary care, around annual physicals, around substance use disorder? We shouldn't have to have had a pandemic to force us to do things that we know make sense. So to answer your question, I think we've learned a lot. And on that panel this morning, and on this panel, I'll say, what we do very well is we go back to the way we used to do things. And that terrifies me, because there's going to be another pandemic. And we won't have PPE, and we'll be rationing ventilators, and we won't be able to reach black, brown, non-English speaking communities again, but for the efforts like the Health Equity Compact that are saying, no, not again. We learned it, now what do we do about it to make sure that folks don't lose family members like the stories we've heard today? I don't know how to, and I'll say this on the last comment on this, and health centers are phenomenal in this space. Dr. Geiger, Count Gibson, Dr. Hatch, who I got to meet a few months ago, he invited me to speak at his forum in down south. And Dr. Smith in Mississippi, who still practices in his 90s, they never started health centers just for care. It was never just about treating your disease. It was also about solving for the conditions that made you sick. So as all the health centers in this room will tell you, they were trying to make sure people had access to safe and clean water. They were trying to make sure that's why our boards are 50+% consumers. That's what it means if Juan's sitting on Guale's board, he can say, you know what, I'm not happy with how they treated me at the front desk. Or I don't like how unclean the waiting room is. Or I don't think the doctor spoke my language or understands my culture. That's a radical change in how we do healthcare. So that the people sitting closest to the power are the people closest to the pain. Ayanna Pressley. So I think we have a phenomenal, how do we build that model throughout the healthcare system? And I think how do we now, and last but not least, unweathering. I say it everywhere I go because I think it's the dopest phrase I ever learned in my life, is the fact that we've been weathered to disease. Geronimus, the researcher, University of Michigan, women's fertility, black women, safer pregnancies in their teens. It gets unsafe as you get older, white women, 20s and 30s, social conditions that make you sick. And I thought about, when they introduced it to me, they said asthma. Asthma is the great example. I had asthma. My mother has asthma. Sister has asthma. And we spent a lot of time in the emergency room at Boston City Hospital. And the researchers said they asked black parents to rate their kids' asthma from 1 to 10, and they were 3, 4s, and 5s. My mother probably would have done the same. Then they asked the doctor to rate those same kids. They were 8, 9s, and 10s. And they said those families had gotten used to the Albupen and Flovent 3, 4 times a day, sitting out the gym like I did at Martin Luther King Middle School, or not going to work like my mother did, or sitting in the hospital once a quarter. We're weathered to a lot of stuff. The violence and trauma in our neighborhoods. I've lost 2 nephews. The fact that you have to live in communities where there are gunshots, where our murders don't get solved. The fact that we live in communities where we're not hired, not employed, not paid the same. The fact that we are still, 21 years later after Institute of Medicine's report, not treated the same by the healthcare system. Unequal treatment. 21 years ago. Is still true today. Doctors don't believe our pain when we say it. They don't medicate us the same. We have to be really, really disruptive. And that's what I love about this group of folks, that we become like partners in crime together. It is really partners in crime. Because it gets you in trouble to speak truth to power. Is that we're now in this place where we can demand that systems do right by our people and by our communities.
Dr. Ojikutu, I'm coming to you next. I also just want to do a quick, I don't have a watch or a clock on me, so I'm just doing a time check. If anyone can let us know if we have... Okay, all right, wonderful, sounds great. So, Dr. Ojikutu, I mean, I'm hearing Michael, I'm hearing Senator Miranda talk about, getting their vaccinations in the community. I got one of mine at Whittier Street Health Center. I remember going to get COVID tests in Codman Square. I remember, you all did the vaccination clinic at White Stadium. I had to shout out my girl Melissa, because I know she worked really hard on doing that, my fellow NBA sister up in here. But how do we make that scalable, right? So that it's not just that we're doing that for COVID, but we're doing that for things like, for maternal health, for survivors of trauma, all of those sorts of things.
So I think that's one of the reasons why we're here today, to take these lessons learned and actually apply them to these pervasive disparities. I think one of the comments that was made in the previous panel was that we need to do something drastically differently. There's a lot that's being done and a lot that has been done, but are we really being as visionary as we could be? Are we really being as bold as we should be? I don't think so. And it's things like what you're saying, well, why don't we have closer, access to, say, whatever it is, it's a flu vaccination, or if it's anything else, primary care, why don't we have mass systems that will handle those needs and put it in communities, put it in neighborhoods where it's close to where people live. But I also think, and one of the things that I've heard and has been said multiple times, is that it seems like there's a lot that people are doing. It seems like there's a lot of individual change makers, a lot of organizations that are doing a lot of great things. And one of the questions that I have is, maybe one of the problems is we're not working as collectively as we should. And that's something that we learned during COVID, is if we have a unified focus, if we have a common foe, we can do things together without competing against each other and get it done. That happened during COVID-19 in regards to vaccination. We scaled up together. So it wasn't just the Boston Public Health Commission running X. It was the Boston Public Health Commission plus the community health centers, plus the hospitals, plus the Mass League, plus all the institutions and all the community-based organizations like the Black Boston COVID Coalition, like La Colaborativa, like Equity Now and Beyond. It was us working collectively. I think one of the things that the Health Equity Compact does is that it brings leaders in the room to at least start that process, okay? These are leaders. Most of them are Black and brown. We've now expanded beyond that. There are probably about 65 individuals. And bringing us to the table to at least say, look, there is a way that we can advocate together for this very large omnibus bill, but we can do it together because there is power in numbers. We can amplify our impact. These are all people who've been doing equity work for such a long period of time, but they've been doing it in isolation in some cases. They've been doing it alone and they've been siloed. So why not do it together? Maybe that is one of the changes that we need to make. We need to stop working alone. We need to stop competing against each other with a lot of our different activities. And I'm going to be transparent. I'm talking about how sometimes as hospitals and as other entities that invest. Why can't we invest together? Why can't we take our community health improvement plan and do that as one? I mean, maybe that is something that we can do that is doing something that is truly different, that has not been done here in Boston. That is what I want us to think about. What are the things that we can do that are truly different? And the Act to Advance Health Equity is one of those things that is truly different.
And if I could follow up on that and ask too, I mean, I guess I'm also thinking about everyday people, right, who say, okay, you know, I hate going to the doctor. I don't trust the doctor. I don't trust our healthcare system, but I might trust a doula I know in my community, right? I might trust someone from, you know, there's a New England Drug Users Union, people who are all about, what is the term? Harm reduction. There we go. Thank you. Y'all are in the healthcare space, not me. Right? No, thank you. But harm reduction, and want to sort of be in those communities, but also have the backing of our public officials who are in these spaces. How can they get involved?
Well, they have been involved. What I would say the problem is that they don't have the resources oftentimes. We're not funding them to be involved. Our community-based organizations, oftentimes, they're just not getting the resources to actually do the work. They want to do the work. They have the solutions. They even, sometimes you have some more of the staff than some of us do in some cases. They have people who want to do the work, but they don't necessarily have the funding to do the work. And I think it's one of the things that we are trying to do, and I was going to mention this in the closing, and Melissa Hector was also working on this. We at the Boston Public Health Commission are going to issue an RFP for a Community Health Equity Empowerment Fund. And the point of this Community Health Equity Empowerment Fund, we're calling it CHIEF. I don't know if that helps at all. But is to fund community-based organizations to partner with community health centers, with other institutions, so that they can do some of the work on their own, so they can actually lead. So all the things that the coalition were doing during COVID, they can take that to look at these pervasive inequities, the chronic diseases, other infectious diseases, things that we know we need to work on. We need to start realizing that the power has to be shifted. We cannot control the power within institutions, within our organizations. The community has to have that power, and that also is something a little different.
And Dr. Pierre, you mentioned earlier the pushback that there's been to initiatives like United Against Racism with neo-Nazis protesting. I will give a shout out to my GBH colleague, Philip Martin, who's done a lot of reporting on this. That's not going to stop, right? We know that there's growing rates of anti-Semitism all over the country and in Massachusetts. And the more that these initiatives happen, the more that we pull in community-based resources like Dr. Ojikutu is talking about, we're gonna see people show up more often. So how to defend these initiatives against that kind of activity?
It's extremely hard, but extremely important, because that speaks to the national and actually global trends, right? And so as we have more and more data, which we do, showing the disparities, as we start to move towards solutions, which is exactly what we do, we have to continue to write about it, and we have to continue to do the work, and we will get opposition. And it turns out, I think, there's silver lining in it, because for every time there's coverage about whatever it was, I think last time it was the Brigham kills white people, which was because we were helping black people. So if you're helping black people, you must therefore be killing white people. We realized that gave us an opportunity to have a dialogue within our staff in a way that we wouldn't have. We were not talking to security in a different way. We're talking to communications in a different way. We're talking to our policymakers in a different way. So although it is difficult to respond every time we get attacked for actually fighting inequities, many of us, the insomniacs, we've actually been in that space very often. We've been, some of us who chose this career were told, did you not want to be a doctor? And so not only are we used to it, we are also bringing along more people who understand how important it is, and we're bringing to light how this needs to be covered, not just within our rooms, but across our disciplines, across our departments, and beyond our borders.
So I want to make sure that we're leaving time for audience questions. I believe we have about 5 minutes left here, so if anyone would like to ask a question, please do.
Can I make a quick comment? So I'd be remiss if I didn't do this. There's always people behind a movement that no one ever reads about, right? And because I'm a student of movements, there's so many of them, right? And they're not the Dr. Kings or the Rosa Parks or the Diane Nashes. In this movement around health equity in Massachusetts, there's some folks in the room who've really been at the table to do this work. MPHA, Carlene Pavlos is here. I want to give them credit for the work that they do. and really organizing us around this health equity work. Juan, Jeffrey, Manny Lopes, Rosa Colon, Nancy Norman, Filane from SEIU, really made some really smart decisions as sort of the organizing group around the Health Equity Compact about hiring some really smart people who really moved the needle on this work. So I want to give Lindsay Tucker, the former Associate Commissioner for DPH, a lot of credit, because Juan and I got to work on the Hague, the Health Equity Advisory Group, and she was phenomenal, and she listened, and then she acted on what we told her. So we knew we needed to hire her when she left the administration. JSI, John Snow Institute. You worked for John Snow, did you? No, you worked for Partners in Health. JSI. That's how no wonder you work for JSI. So John Snow Institute, Angel, and the rest of the team from JSI has been phenomenal. They've been our technical partner from the very beginning. And then we hired these young, dynamic public health activists, young people who've been featured in some articles recently. Can I ask the folks who are working on the Health Equity Compact to stand up, please? Yeah, please. Give a round of applause. If you really want to make a movement, bring people together and hire really passionate people who want to get the work done.
And did we have a question in the back there?
Good afternoon. I'm Jenny Lobo-Lopes, Senior Director of Health Services for Boston Public Schools. Boston, Roxbury, hi. And so I don't know if it's a statement, a question. I just been listening all day and just kind of putting things together, and I just keep thinking about the kids because that's what we do every day. And we work closely with Boston Public Health Commission with COVID. And I feel like we've gotten a lot of light because of COVID, whether it's like public schools or school nursing, and I don't want to lose that. There's a lot of communicable diseases that we deal with outside of COVID. And so I just wanted to say that more of a plug, that when we think about community and we think about the schools, because we're a large district, we are the community. And so like Dr. Hall said, one student is like a whole family. And we think about the apartment they live in, the conditions, everything in our daily work. And so I just wanted to kind of say that for everyone in the room, because we partner with many hospitals and community centers, and because of COVID, we haven't been able to do it the way we would like to. And I feel like I would need to talk to everyone in this room to collaborate and do really great partnership work for our kids. And so whatever we're doing, that we always think about BPS, our kids, how we can uplift them, how we can help our students who want to become and nurses or whatever they want to be, to know that they can, and how those partnerships can work, because we have all the jewels within our schools. And so I just wanted to just say that, more of a statement, that we think about the kids that we have in our schools.
Thank you.
Maybe a quick reaction to that. So one is know that one of the things I love about this work at community health centers is that many health centers have school-based health centers too. And having visited school-based health centers, it made me even more appreciative of the role of school nurses in dealing with our mental health, our physical health, the trauma that we often deal with in communities across this Commonwealth, across this country. So know that I think that attention that school nurses, that our kids have received, that are dealing with those conditions in school, many of us want to keep lifting that up, and even advocate for more investment in school-based health centers so that we have that care being provided. I will tell you that for me growing up in Roxbury, there was, I was an inner city kid. My school nurse was like family to us. We got our care. Whittier Street Health Center, and our school nurse was the person who engaged me when we had violence and trauma in our school or in our neighborhood. So I personally, and I think many of us in the room, share that deep passion for the role of school nurses, and to make sure that we're investing in them, because the defunding of our systems includes our school nurses, that leaves you without the resources to even respond to the needs of our kids.
We have one other question back here. I believe we have time for one more. Okay.
Very quickly, one, just really thank you for this incredible panel in terms of the wealth of experience that you're talking about. As a follow-up to what you were saying about the centers with Jack Geiger and John Hatchett, there's a video that you can see, and if people don't know it, you should. It's called Out in the Rural. So if you Google it, it's Out in the Rural. It's 22 minutes. It was filmed in 1970 after the health centers were set up in Mississippi. And it is an extraordinary, I show it to my students every year. And I just really urge you, because it gives that movement history, and it gives that history of community health centers, and it gives it as being way bigger than the healthcare itself. At the same time, absolutely the vital necessity of that healthcare and training people to do it. So I know that not always, a lot of people don't always know about that video. It's free, it's on Vimeo, and it's again, Out in the Rural. The other question I have, and Senator Miranda, I'm very grateful to be one of your constituents, is I'm aware that there's this controversy going on right now in the legislature about Fair Share Amendment and about the attempts to claw back by rich people the money that is meant to be set up. I am wondering where health equity can come into the conversation about fighting to shape that, because it seems that the fair share framing has been a useful one in terms of talking about where the resources are actually should come from because of what has been inequitable in the tax rates in Massachusetts. And if health equity could be linked to that to fund the kinds of things that you're all talking about.
Thank you for that. So just quickly, my team is in the back of the room, and the House is in their budget week, but the Senate will have their budget week at the end of May. And we actually decided today that we're gonna handle the tax relief package actually after we do the budget. And I gave a pretty impassioned speech on how the House's package would actually worsen and deepen the racial wealth gap and the gender pay gap, not only here in Massachusetts, but we see these trends. There's concentrated wealth around white families, and just to give you one fact, tax breaks go to 92% of white families, or 92% of the folks who get tax breaks are white families, 3% are Latino, and 2% are Black. And Massachusetts is great, like you said, best to worst, but we have huge income inequality here in the Commonwealth, and we shouldn't be giving rich people more money or more breaks. We should be focusing on the middle class people, because that's actually who's leaving. They keep writing articles that we're not making Massachusetts competitive, but the truth of the matter is when someone from Roxbury has to move to Taunton or Fall River or New Bedford, they're great communities, but they're not from there because they can't afford to eat and live in the same place. We're in a bad situation in the Commonwealth of Massachusetts, so you could talk to me afterwards.
We just have 2 more questions.
Well, unfortunately, we are out of time, but I want to thank each of our panelists for just all the work that you do. Thank you all for having me here as well. I've really enjoyed this conversation. And Dr. Ojikutu, I'll pass it back to you to close us out.
Okay, sure. So I know we've been here, and this has been a really long day. I've sort of felt that there's a good feeling in this room. You know, there's an excitement. I feel like we've achieved our mission in sort of establishing a renewed call for action. I feel like we're ready to kind of get up and go. I think we're all aware, at least I hope everybody in the room is aware, that we need to do something differently. We need some bold, new action. Many of you have proposed solutions. I mentioned a few things that Boston Public Health Commission will be doing in terms of the Community Health Equity Empowerment Fund. We would love for other institutions to join us, because I believe collective power is the way to go. I believe that is how we will change things. But given all that we've learned thus far, I still feel like there's more that some of you may want to share, and I'd like to open up the floor for the next 10 minutes or so for you to share what you want to do differently. I'm talking about what you, your organization, you personally, what is it that you want to do differently? If we know these difficult, challenging, pervasive inequities have existed, we know where we are in terms of life expectancy. I provided that data at the very beginning, 23 years life expectancy difference. What is it that you want to do differently after hearing what you've heard today, after thinking about it? I know many of you all have been in this world for such a long time, in the world of inequity and dealing and struggling for such a long time. Why don't we do some sharing just for this last period of time?
I think we have some thoughts over here. Oh, I guess it's on now. Hey, everybody, my name is Brandon Ransom. I run a local web design firm dedicated to addressing the social determinants of health called Include Web Design. It's my lovely wife and I. And one of the things that really stuck out to me today was the opportunity for collaboration. We're contractors, right? So we basically are an outsourcing of your chief technology officer. People usually come to us with like, hey, I have this specific problem, but we over and over and over again get asked the same problems. Everybody's like, hey, we need to make a directory to get access to this information and everybody to connect because nobody knows when stuff is going on, right? I keep getting the same stuff over and over again, and I would love to have more conversations with folks in this room about how do we break down these silos and have these conversations at an earlier point, right? We're all talking about the same problems. Everybody wants their baby to look better, be in a better school, not have access to healthy foods, and we're having these conversations on Zoom and not necessarily in a broader dialogue. So happy that this space was provided.
So thank you. Senator Wilkerson?
Was somebody supposed to respond to you? Or
No. We're just sharing. We're just spending some time sharing. Love to hear from you.
So, I think that Dr. Ojikutu is onto something. These last two panels have been incredible, informative. The one around solutions and what's happening differently. But here's the point, and I think that, I guess my question to you, or maybe even notice to you, is that we gotta push you a little farther. Because with all of that work that's being done, the needle is moving in the wrong direction, which means that we gotta keep trying to figure out what we do differently. I actually think that one of the issues is the silos that we work in. I'm listening to the incredible work Michael talked about, the health impact. And at the same time, you know, the Black Agenda is meeting this weekend. You know, there'll be 100 people. We've been talking and meeting with people for the last, in Roxbury, Dorchester, Mattapan, the last 2-3 months in earnest and in person now, because we come off Zoom, around the whole contemporations model, which meets the health equity, the eradicate the gap in school, the need to focus on Black and Latino business opportunity, because here's the bottom line. The city of Boston is doing their budget right now, the House is doing their budget right now, and the Senate will be at the budget. This is the first time, I think you said it, Mike, this is the first time in life that we've actually had resources. We've been fighting. We have resources that are time limited, right? I am under the impression that the ARPA funds, for example, were supposed to be used targeting to the communities that suffered the most during COVID. So I can ask out loud, why are we spending ARPA dollars in West Roxbury? That doesn't make any sense to me. And so people get upset when we say that, but that's the question, right? So we have the money right now. The question is, what are we going to do about that? Because I think we need to be in the same room. We have to be in the same room. And you mentioned that issue, Dr. Ojikutu. This is our time to do it, I think. It's just absolutely has to be our time to do it. But it's not happening. I'm excited, like I said, about what I heard in the last panel and in this one, especially around all of the work that is going on with the individual entities. That's the problem. That's the problem. You know, Michael, you were there. I think Dr. White Hammond was present. We met with the new president of Brigham and Women on the day he came to Boston. I think he said his luggage was still in the car. He said he wanted to be in community, right? Meet with community, and that was first. And the reality is, as excited as we were in November 2021, when we met with him, I have not seen that. And part of it is the way that the process is done, that they all talk together, but everybody has their own Chip-Chinna plan. How is that a plan if everybody's doing it differently?
So let me just say, just so everybody understands, that the Chinna CHIP is the Community Health Needs Assessment, and the CHIP is the Community Health Improvement Plan. You know, I think one of the things that I commented on earlier, and other folks, I know, you know, Rosa, Sherry, you know, we should say, if you want to say something about it, what's happening with the chip is that institutions are doing their own work. You know, they're working in silos, and I'm not saying silo negatively, I'm just saying that institutions are doing that for the most part. And feel free, we can dialogue about this, but I think it's important for us to think about how do we do this more collectively and strategically together? I would love to hear some thoughts about that, just because, again, this is what we're talking about, thinking about upstream. Because in the Chana, we're talking about housing, we're talking about mental health services, we're talking about access to services, and we're talking about employment and economic mobility. That's what we're talking about. These are all the things that we've talked about will change life expectancy. So then, what is it and how is it that we can work together on that? And would love to hear any comments from anyone.
Since I'm right next to you, I'll say that the beginnings are happening, but I'll let Sherry comment more on that because I think there's hope on that part. Sherry, you want to? No problem.
So Sherry Nethersoul, Boston Children's Hospital, and I have been part of this work for more than 30 years. I've been a pediatrician and also I'm the VP for Community Health for those people who don't know me. But we've been working on these issues for a while. We have come together to collectively address them. I think the challenges are things that have been mentioned already. Resources. I think we could come up with a list of 10 different things that we want to do, and the question is how do you prioritize those? Because I think there is a will and an interest in collaborating and for people to do that work together. But how you prioritize that, and I'll sort of raise my own priorities here, which are children. You know, we've had a lot of discussions today, but for me, upstream is birth to 5. And so how do we think about what we can do to truly change health outcomes 20, 30 years from now by focusing on that 0 to 5 population? But that might not be someone else's priority at this point. And so that's one of the things that I think has contributed to some of the challenges we've had with working collaboratively. But I do think that it's possible, and I do think we are actually on that path between the work of the Compact, between the work that we've had with the Chana chip, and between some of the other work we've had at the state level to talk about how we address some of the cardiometabolic risk.
And if it's okay, I'll just add to that that there are many in this room who have actually been thinking about this for a long time. And one of the things we have to do is, as you say, Dr. Ojikutu, is not just to do a chip together, but to actually invest together in maybe one major area. Economic mobility is an example that comes up every time we do the community health needs assessment. And every time we interpret it as like, we can give, X amount, we can give a training for how to save money and so on and so forth. Dr. Betancourt just told us that there are private sectors out there, there are people out there who are looking at 25-year-olds and giving them $20 million to start businesses. We are looking at extremely talented, skilled, both in terms of their training and experience, as well as in terms of their lived experience, community leaders who are giving us solutions, and we're like, maybe we'll distribute some, et cetera, right? And so I think you are right in that we need to, one, shed our institutional identities, and then two, come together towards 1 or 2 or 3, but very small and very clear goals, because our communities have told us over and over what the themes are, and then have measurable outcomes and do real investment, not small investments that will actually move the needle, because structural racism is not just about addressing the day-to-day issues, which we should, but actually multi-million-dollar investments across long periods of time until we see the change.
We have one more question
Hi.
over here, and then one here. Okay, yep, we have one on the left and one on the right. Yes.
I think I'm the okay. Anyway, thank you so much for getting us all together. This has been amazing. As someone who's always worked in community health centers after completing residency, it's really wonderful to see that we can be all so committed to CHCs. In my new role at Dodd House Health Center, a lot of what I think about is how do we diversify our clinical workforce, and we have so many schools and great institutions. I went to Morehouse School of Medicine. I was with amazing people. And when I think about how we can diversify that workforce, one thing that keeps coming back to mind is why would a BIPOC clinician come here? Because they don't have the generational wealth that other people do to be able to work at a community health center. So even though we have done a lot as far as like increasing salaries and being competitive, we still aren't at that place where, you know, a child comes in to our clinic and sees a pediatrician, and seeing a black or brown one isn't a rare thing, right? So I think one thing that I'd love to see as a group, people thinking about, is how do we go upstream with investing in clinicians who may not have that generational wealth, who may be thinking about the fact that they're the first to graduate college, graduate school, and, you know, need to help support their family in many ways.
Absolutely, we appreciate it.
I'd love to say something on this, because I feel it's such a critical part. So, you know, I used to tell people when I was president of NAACP that no one understands the challenge that we face like an NAACP president. And the reason I used to say that is because most of the people go to bed at night and they don't see on every wall around us is 1,000 drop-down list issues that we got to deal with. One of them that I often thought about in this health equity space that used to bother me was the lack of black and brown physicians. Data just came out, research that I just shared with the team at the Mass League, that in communities with black physicians, people are living longer lives. Now, I used to say from a standpoint of why, right? Why is that if you have a physician who's a woman dealing with a woman who's pregnant, or dealing with issues that she may have, or a black person, or a person who speaks Spanish who's Honduran or Costa Rican, why does that matter? But of course we know why that matters, because you get different treatment. Because people can identify and connect with your experience, and they hear you in a different way. I say that to say that to me, of the many urgent issues we have to solve for this crisis, and I said this earlier today, and for the folks in the compact who hear me say this all the time, I'm sorry, but I'm gonna repeat it here. I always say there's a little black girl in Roxbury right now meant to find a cure for cancer. We'll never know her. If you don't have a white supremacist mentality, so when you walk into rooms, and like I was in many rooms this week, all white male, some white females who are physicians, I'm irritated by that. I'm visibly irritated, because I understand that there's talent is not restricted to white men, and we have to solve for that. And that means there's an urgency that we find the right programs in our grade schools, our elementary schools. Black and brown physicians are reporting they're being steered away from their specialties through residency, because they're facing this gauntlet of discrimination that the doctors in this room could speak to, people derailing you from what you were intended to do. So I do think health centers, you'll find more physicians and people of color in those spaces, but even we have a struggle, because it's hard to recruit them, pay them a salary that will compete with the hospitals and the private practices, and then to your point, they can't afford to live in some of the cities where we're located, and then we lose them to other higher paying, less costly environments. I think loan repayment is one of those models that the state, $130 million plus posited with the Mass League, or at least we're helping to distribute those resources to get people to say, we'll pay your loans while you work, and we can retain you within our settings. That's one small piece of the puzzle, but we got to figure that out. It scares me, Senator Wilkerson, Reverend Mariama White-Hammond, that there's a deferred crisis issue in this country right now. People did not come in to get their care because they couldn't come in for care. And now, even if they want to come back, we can't even see them because of the workforce crisis. So that means stage 1 is stage 4. That means your teeth have a more severe oral health issue, Maisha Minter-Jordan, your mental health, Nancy Norman, your substance use disorders, all gonna be worse, and we'll have shorter life expectancy. Earlier panel spoke to this. We're gonna see stuff that we shouldn't have to wait on the data to tell us. All of that terrifies me, and physician diversity is one of the most critical ones.
Hi, so I'm Trina Martin. I am the Vice President of Community Engagement and External Affairs at Boston Medical Center, and I really want to just echo what's been said, that we have been talking to community members and leaders and asking, like, what are some of the things that we need to be doing? And they've been saying exactly what we've said here: access to economic mobility, access to workforce development. And so we have at BMC have removed those silos by working with folks like Mass Life Sciences, Mass Bio, and leaders of educational institutions to try to figure out how do we create pathways to some of the 40,000 jobs that are available in biotech by making sure that community members are trained and they have access to these jobs. Using our determination of needs funds to give dollars to businesses like Nubian Markets in Roxbury so that we are uplifting and providing access to businesses and making sure that they continue to be successful by, bringing folks in and adding folks to the capital stack to make sure that they're successful. Partnering with other anchor institutions like the Boys and Girls Club and helping them create a strategic plan that includes wellness and health, not just to help the club members, but also staff and communities. So I think to the earlier points, whenever we can find opportunities to work with other existing organizations so that we're all working together to do that, that's what we should be doing. So thank you for creating this space today. I think it's really amazing. And I think the solutions are in this room. I think Dr. Pierre said it, the dots are here. We are all the dots. We just have to figure out how to connect those dots. So thanks.
That's right. That's right. So this has been wonderful, but this can't be the end. It certainly can't be the end of the discussions. I think that one of our roles as the Boston Public Health Commission is to convene, and we've sort of lifted ourselves out of the COVID, sort of haze, in a sense, bringing people together in person. We're going to do this again. We'll make, a plan, we'll have a schedule, we'll have time for us to share solutions, for us to partner, for us to work together to make collaborative solutions. So that's what we need to do, and that's what I'm saying my organization needs to do. We've created momentum, and I certainly don't want to lose it. So this is the end of our conference, and I just want to thank you again and appreciate all of you all for being here. I also want to organizing committee, many of whom who are here in the room, many of who have been here since very early this morning, and that includes Bill Adams, Cheryl Clark, Tim Hesselton, Natalia Linos, Takanami, and Lindsay Tucker, as well as Catherine Hall and Jen Goldsmith. None of this would have happened without their work. I also want to thank my staff at the Boston Public Health Commission. We have about 14 of our staff members who volunteered today. I really just appreciate their tireless energy. There's a lot that we do in public health that nobody pays any attention to. We don't tend to get the value that, and the appreciation that I think that we deserve, and I just want to appreciate them. So we can give them a round of applause too. And lastly, the discussion does not need to end here tonight. Hopefully you all can stay. We have a reception who is co-sponsoring the reception, Catherine? Oh, okay, FXB. Thank you so much, Natalia. Thank you for your partnership and for sponsoring the reception. That's going to be held in the McKim Exhibition Hall, which is just right down the hallway, which is where we were before. Please stay, please enjoy, please let's continue the discussion, and thank you so much for coming out.